Hello, my name is Professor Susana Banerjee. I'm a medical oncologist practicing at the Royal Marsden Hospital in London. And I'm really delighted to be having this opportunity to give an overview what's happened in the last year or so in endometrial and cervical cancer. So much has happened, and in particular, focus on ASCO, which was earlier this year. So I've selected a few abstracts, some papers, which really I want to cover as some take-home messages, things that are looking promising, but also things that we have in practice, and looking at how we can integrate into practice now, or whether things aren't quite ready for prime time yet. So I'm going to kick off talking about endometrial cancer, and here are some of the abstracts that I will cover. Immunotherapy has revolutionized the care of our patients in clinic, and it's so great that we've got effective treatments now, thanks to phase 3 clinical trials, and we have a number of immunotherapy approaches now in the first-line advanced and recurrent endometrial cancer setting. So today I'm going to mention the overall survival analysis from the RUBY study and also the NRG-GY018 of pembrolizumab overall survival analysis. In addition to this, we'll look at some patient subgroups, looking at RUBY Part 2, which is looking at the addition of a PARP inhibitor, and also the DUO-E study of durvalumab with chemotherapy, and then also the addition of olaparib. But what we're going to focus on is some results from ASCO looking at the role or potential role of circulating tumor DNA. I'm also going to talk about non-immunotherapy maintenance therapy because there is treatment and we need to develop treatments beyond immunotherapy or alternatives to immunotherapy. And so we're going to look at the SIENDO study, which is a non-immunotherapy maintenance approach, and changing direction, actually looking at some results of looking at molecular residual disease detection. So let's start with the RUBY study. Now, this was a phase 3 randomized, double-blinded, multi-center study. And this looked at dostarlimab, a PD-1 inhibitor, with our standard of care carboplatin and paclitaxel, or our standard of care, which is without dostarlimab. And then the important point is that the dostarlimab in the study was either continued as maintenance therapy, or in the non-dostarlimab arm, this was just placebo. So a key point is that patients were included that had stage 3 or 4 disease or first recurrent endometrial cancer. And carcinosarcoma, as well as clear cell, serous, and some mixed histologies were permitted. So patients needed to be naive to systemic anti-cancer therapy or have a recurrence or progression more than 6 months after completing systemic anti-cancer therapy. So these are patients that we see every day in our clinic, and I just thought it was important to remind ourselves of the study design as this has changed practice given the approvals. So FDA approval was in August 2024, and EMA, so European approval, was slightly later in 2025. And dostarlimab with carboplatin and paclitaxel, followed by single-agent dostarlimab, so as a maintenance approach, in primary advanced or recurrent endometrial cancer, is approved regardless of mismatch repair status. And what I'm highlighting here is the overall survival publication in Annals of Oncology in 2024. So this was almost 500 patients randomized. This was a second interim analysis with 51% maturity. And the key take-home message is that the overall population, so regardless of MMR status, there was a statistically and clinically meaningful significant reduction in the risk of death. So that's a hazard ratio 0.69 with the addition of dostarlimab to our backbone of chemotherapy, carboplatin and paclitaxel. versus what was our standard of care, carboplatin and paclitaxel alone. So if we look at the median overall survival, to put it into context, this was about 44, 45 months versus 28 months. So there were further analyses, pre-specified but exploratory, because in everyday practice, we want to see MMR deficient or MSI high, and also how we class endometrial cancer as MMR proficient or microsatellite stable. So I've shown you here on these slides, looking at the risk of death was lower in the dMMR MSI high population. That's very clear. The median overall survival hasn't been reached there versus 31.4 months. And that hazard ratio is 0.32. But there is a trend also in favor of dostarlimab in that MMR proficient population. So hence you see what's been approved. This is really important when we're counseling patients in clinic. I'm going to move on now to the other practice-changing phase 3 study of pembrolizumab. Same sort of design in the terms of carboplatin and paclitaxel as our standard of care versus carboplatin paclitaxel with pembrolizumab and continued as a maintenance therapy. What's really important is that the primary endpoint was progression-free survival in the intention to treat, but also there were defined populations of the pMMR and also the dMMR population. And you can see the results here. The median progression-free survival was better, 13 months versus 8.7 months, with a hazard ratio of 0.57 in the pMMR population. And in the dMMR population, progression-free survival median not reached versus 8 months or so in the chemotherapy arms. The hazard ratio is meaningful, 0.34, and clearly highly statistically significant. So this is what has changed our practice, and this is an secondary endpoint, which is immature, which is that overall survival I talked about in this publication. It's an ad hoc analysis, but what we do see is the hazard ratio 0.57 in the MMR deficient population and 0.8 in the pMMR. So what we're consistently seeing is that the magnitude of benefit is greater in the MMR deficient population, but it's also meaningful in the pMMR population and a step forward compared to carboplatin and paclitaxel. So I think this has been real progress in the field of first-line endometrial cancer. So how do we build upon this? What else is going on in the trial arena and potentially then impacting on our practice? Well, I just showed you Ruby Part 1 with dostarlimab. Ruby Part 2 looked at stage 3 and 4 patients and first recurrent disease, naive to systemic therapy, so similar design, or recurrence or progression more than 6 months after completing systemic therapy. Here, the question is dostarlimab with chemotherapy, followed by dostarlimab with the PARP inhibitor niraparib, versus the placebo with chemotherapy and placebo. So I'm going to take a few moments just looking at that design. Primary endpoint, progression-free survival by investigator. So here were the outcomes, and the message here is, yes, there are statistically significant benefit in the MMR proficient and also clinically relevant PFS difference in the MMR deficient. But I think the key question here is, what is the role, or how do we integrate a PARP inhibitor? There was no dostarlimab alone arm here in Ruby Part 2. So what is the magnitude of benefit with the addition of niraparib compared to dostarlimab alone, for example? So of course we have some of that information from Ruby Part 1, but I think it's very interesting to learn from Part 2 and also some of the subsequent subgroup analyses that we'll see. But let's move on to another trial, a randomized phase 3 study that also looked at the addition of a PARP inhibitor to immunotherapy. So the DUO-E study is published in the Journal of Clinical Oncology, and I'm just reminding you here of the design. I'm not going to go into too much detail, but really you can see it's the same principle: chemotherapy, maintenance placebo, chemotherapy plus IO, durvalumab this time, versus maintenance durvalumab, or chemotherapy and durvalumab with durvalumab and olaparib. So note here, this is about the addition of a PARP inhibitor, but we don't have a PARP inhibitor alone arm. And here you see the intention to treat population. There was certainly an improvement in terms of progression-free survival with the addition of durvalumab overall, and also in the overall population with olaparib. But then when we break this down further, we see that the greatest benefit with durvalumab versus chemo was in the MMR deficient population, so consistent with what we've seen already with pembrolizumab and dostarlimab. And if we look in the pMMR population, what was interesting was to see that hazard ratio of 0.57 in the durvalumab plus olaparib arm. In the durvalumab arm alone, it was 0.77. So this suggests that in the pMMR population, the addition of olaparib further enhances that benefit in terms of progression-free survival. This was published, as I say already, at ASCO this year. There was a post-hoc exploratory analysis looking at longitudinal ctDNA. And I raise this because there's a theme now looking at more trials currently, and certainly at ASCO, about looking at the utility of ctDNA. So a few bullet points here. Looking at, these are smaller numbers. I didn't go through how many numbers, but you can see on the slide it's a small subset, but interesting signals. Baseline ctDNA positivity was associated with higher risk of progression, whatever treatment you've received, whether it be chemotherapy, with the IO, or with the olaparib. Very interesting data there. And then if we look at this very nice analysis, I'd say, which is looking at changes over time of ctDNA. And if we look in the pMMR population, what we see is durvalumab, or the addition of olaparib first, could be driving activity in pMMR tumors, what we don't see with durvalumab alone. Durvalumab led to more clearance of ctDNA and less of this rebound when you're on treatment versus chemotherapy alone. And interestingly, the addition of olaparib to durvalumab led to 35% more clearance of ctDNA and less rebound, so reactivity, if you like, versus chemotherapy alone. So the key takeaway points by the presenters was that there clearly are changes with ctDNA. I've mentioned the less rebound that we can see with immunotherapy, and then potentially with addition of maintenance olaparib, we can see further reduction of ctDNA. So in my view, this is very interesting. We need to look at this further in more patients. I don't think it's quite ready right now for in our clinical practice, but you'll see similar work on ctDNA in GYN cancers in the remainder of the studies. So moving swiftly on to non-IO maintenance. This is one of study which is looking at selinexor in the SIENDOR study. So this is actually an inhibitor of exportin. So it's a different approach. It's not IO. And what we've seen in this study is that the patients with p53 wild-type tumors appear to derive benefit most. Now, relatively small numbers, as you can see here, in terms of under 100 patients in that subgroup, but very interesting nevertheless. If you look at the median progression-free survival in the p53 wild-type, 28 months versus 5 months. This was published last year. And this is the progression-free survival in more detail. So the take-home message for me is relatively low numbers, but signal of interest. And there's positive results in this subgroup analysis in this TP53 wild type. And that's regardless of MMR status there. And I think that's a strong rationale for further evaluation as a maintenance therapy in TP53 wild type advanced recurrent endometrial cancer. And there is the ongoing phase 3 study now. But the real clinical question and trial question will be, in an era of immunotherapy, how do we then integrate these results or phase 3 results in an era of immunotherapy? So changing direction completely, this is stage 1, so early stage endometrial cancer, but I said we'd come back to ctDNA. This was an interesting paper about post-surgical ctDNA detection rates in patients with stage 1 endometrial cancer. So what we see is that ctDNA is detectable. I appreciate small numbers, but you can see positive and negative and longitudinal changes. And the results essentially show that patients that were ctDNA positive at that first time point or at any point post-surgery had significantly worse relapse-free survival compared to those women that had ctDNA negative samples. And also that an increase in ctDNA levels pre- and post-adjuvant chemotherapy or therapy identified patients experiencing recurrence. So it really is food for thought about serial ctDNA detection, and we need to look at this further. So there are limitations. This is retrospective, real-world, short follow-up, but it also shows the value of real-world experience and potentially to help then develop the right questions in the right trials. So prospective trials are required, in my view, for incorporation of how ctDNA is integrated and what does that mean? Does it affect direct adjuvant therapy, escalation, de-escalation questions, and maintenance therapy according to ctDNA status? So that's endometrial cancer. Some highlights there, and I'm going to move now on to cervical cancer. And we're going to look at recurrent disease, metastatic cervical cancer, so ADCs post first line. We're also going to look at first line advanced recurrent cervical cancer. And I'm going to kick off with 2 abstracts in that post first line setting. And really, it's the world of ADCs now. So in cervical cancer, we're looking at tisotumab, and I'll also talk about trastuzumab deruxtecan. And in the first line setting, I'm going to mention immunotherapy. So let's kick off with tisotumab vedotin in the second or third line study. This drug is the first ADC to have FDA approval across gynae cancers, and a very important study because we all know far too well how in clinical practice our treatments so far are not as effective as we need them to be. So patients are randomized to tisotumab vedotin or what we can use as chemotherapy as standard of care. And the primary endpoint was overall survival here. I was really pleased to be part of the trial team and a co-author on this New England Journal of Medicine manuscript. So here are the practice-changing data. Looking at overall survival as well as progression-free survival, and you do see an improvement in overall survival. Now, the issue is, compared to many other cancers, so clearly this is statistically significant and clinically meaningful for this group of women where survival, frankly, is far too poor. But it's a step forward, but we need to do better. And the response rate, really important with huge burdens of disease. Tisotumab vedotin around 17-18%, yet standard of care chemotherapy only 5%. I'd like to mention here the importance of adverse events because ADCs are different to traditional chemotherapy and our side effect profile is different. And what I want to highlight in particular for tisotumab vedotin as an ADC, that there are ocular adverse events, which we're not used to with traditional chemotherapy. So it's important when we're using this drug in practice to link well in with ophthalmology colleagues, risk of keratitis, risk of conjunctivitis, for example. So the hazard ratio is 0.7, so a 30% reduction in risk of death. And I've highlighted to recognize ocular toxicity. This is a step forward, but the prognosis remains poor and we need further improvements. So that leads me nicely on to the Destiny pan-tumor study of trastuzumab deruxtecan. And to put this in context, based on this study, there's FDA approval for patients with immunohistochemical 3+, tumor agnostic. But of course, I'm focusing here on cervical cancer. And again, I could see firsthand as an investigator in this study the benefit to my patients with cervical cancer, also in the endometrial cancer arms and ovarian cancer arms as well. So overall, the primary endpoint showed a response rate of 37%. And in patients with central HER2 3+ testing, the response rate was 61%, with a median duration of response 22 months. Now, there were some patients actually in the cervical cancer arm that were also enrolled with 1+. So let's focus on cervical cancer here. For the IHC 3+ by local teams, response rate 80%, 2+ 40%. Now, this is really high, small numbers in this study. I appreciate that, but we don't see response rates. I've just told you with standard care chemotherapy in a prospective trial, it was 5%. So I think it's really important in clinical practice to do HER2 testing and, if relevant, offer this drug to patients. So this was single arm, relatively no numbers, positive signals, but you have FDA approval in this setting, and I do feel we also need prospective trials and those results across the world. So now moving on to pembrolizumab plus chemotherapy for advanced recurrent cervical cancer, Keynote 826. So this treatment has revolutionized the care for our women with advanced and recurrent cervical cancer, and really gives us hope about pushing the survival in this setting. So what we've learned from here, because some patients have bevacizumab, but some patients can't have bevacizumab because of contraindications, because where this disease is and risk of bowel perforation or fistulation. So what was really encouraging in this publication in Annals of Oncology this year was that regardless really of bevacizumab use in the PD-L1 positive and the all-comer population, it was clear that the addition of pembrolizumab is helpful. So that's a really good take-home message, that actually in patients both, if they had bevacizumab or they didn't. And similarly, so I just showed you progression-free survival, but also in overall survival. So we can comfortably counsel our patients about the benefit of pembrolizumab in immunotherapy, first line, with our chemotherapy, with or without bevacizumab. So in the final few moments, because I've concentrated on recurrent and metastatic disease, I'm going to mention some progress in locally advanced cervical cancer. So looking at Keynote 18. So can we actually bring forward the improvements we've seen in the metastatic recurrent setting, bringing some drugs forward? Could that actually be of benefit? So that's what the Keynote 18 looked at, with pembrolizumab with chemoradiation in high-risk locally advanced cervical cancer. And the final analysis results of the phase 3 study were presented at ASCO. And with the theme that I've been talking about, I'm also going to talk about ctDNA analyses in cervical cancer. So this was the Keynote 18 design. So I don't actually treat locally advanced early cancer, but I certainly see our patients in the multidisciplinary meetings, and I can see how the need is there and what the benefit of this is. So this was stage 1B2 to 2B, but also stage 3 to 4A. And patients had chemoradiation plus external beam radiotherapy, followed by brachytherapy, plus pembrolizumab, continued pembrolizumab, or placebo. And there's FDA and EMA approval based on these results. So here's the primary endpoint. Progression-free survival at the interim first analysis. The hazard ratio, as you can see, is 0.7, with nice separation of the curves continued. And then this is the descriptive overall survival at final analysis, so a hazard ratio of 0.73. So I think that gives us confidence in considering pembrolizumab in this setting of locally advanced cervical cancer. However, the CALA study, which looked at durvalumab with chemoradiation versus chemoradiation alone, did not show a statistically significant improvement. But I think we can also learn a lot, and that's the benefit of actually having further analyses and also translation analysis. So there was analysis according to ctDNA in terms of a marker of prognosis or indeed activity, because 30 to 50% of patients with locally advanced disease still have recurrent disease within 5 years after standard of care chemoradiation. So this study, in terms of the biomarker analysis, I'm just showing you some aspects. Very similar design, principle of chemoradiation plus durvalumab or placebo. So I'm going to put everything on one side and just talk through what the key results were. So ctDNA was detectable and the rates decreased after treatment and appeared lower with the durvalumab plus chemoradiation versus chemoradiation after 6 cycles. So it's important that we can detect this and it changes. Then we see that low ctDNA at baseline was associated with a reduced risk of both progression and death. Descriptive, I appreciate, and exploratory. And then post-chemoradiation, ctDNA positivity was a negative prognostic factor for survival, progression-free, and overall survival. And then finally, what was interesting is that post-chemoradiation, 68% of patients with ctDNA were detected at cycle 3, day 1, subsequently progressed. So the authors conclude that this supports the utility of this ultra-sensitive tumor ctDNA analysis to help guide treatment decisions in the future. To put simply, high baseline ctDNA levels increase risk of progression and death. Undetectable after treatment, reduced risk of progression and death. So what's the next steps? How are we going to integrate this and how can we integrate this hopefully prospectively into clinical trials? And I just want to take a moment talking about ctDNA because the assays have evolved over the years. And it is important to think about our limit of detection. But as assays become more sensitive or ultra-sensitive, perhaps there is a role. We've seen this in other cancers at ASCO, for example, in breast cancer, colorectal cancer, but perhaps this is a time to look at this more closely in gynecological cancers. So my take-home messages are immunotherapy, change standard of care first line, advanced recurrent endometrial cancer. But we need to look at other maintenance strategies, perhaps selinexor in p53 wild-type disease. ADCs, this is an era of ADCs. It's changing the standard of care in cervical cancer. But our clinical trials currently, there's a host of them in endometrial cancer as well. So watch this space. Tisotumab vedotin, TDXD, all relevant now, approved in cervical cancer. Bringing drugs earlier in locally advanced cervical cancer, pembrolizumab's changed the standard of care. And finally, ctDNA in endometrial cancer and cervical cancer is promising, so let's watch this space.